find challenges in determining the forward and the reverse blood grouping if there is a discrepancy, there is an anomaly, there is a situation that the patient is undergoing which is interfering with the reactions that are expected, are interfering with the reactions of the antigens, are interfering with the reactions of the antibodies. These exist and we just have to be mindful of them. As it relates to type 1 discrepancies, I was almost going to say type 1 diabetes, but it is actually discrepancies. We're not talking about diabetes in this sitting. We may speak about diabetes when we're doing the chemistry review. But as it relates to the group 1 discrepancies, as I had alluded to prior, that the pivotal changing point of me electing to become a laboratory medicine practitioner was the concept of the chimeras. So in the type 1 discrepancies, we have a system that exists. We have a situation that exists that we call chimerism, right? And it is just defined in brief as the presence of two cell population in a single individual. So you have one person with two different cell populations. So instead of having A or B or O or AB, you have a combination of two populations. So that there is basically what is considered to be a chimera situation. And this chimerism was discovered in twins born to a group O mother and a group B father. So usually if a person is O, we're expecting them to have OO. And for B, we're expecting them to have BB or BO. So in that situation, the person can be O and the person can be, that's the offspring we're talking about, and the offspring can also be B, because the O can come from the mother and one O can come from the father if the father is BO. And that there would give you the O. The B would be derived from a BO father giving the B and receiving the O. So when that happens, the child, the offspring, would be B. Or if the father is BB, then you will still pass on only the B and take on the O, and that would produce a B child. So that is basically what is the expected result that we would foresee for a combination of this nature. So as we were saying, that this chimera situation was discovered in twins born to a group O mother and a group B father with a mixture of both the B and the O cells instead of the expected B or O being expressed. Based on our combination, we understand what is taking place. So instead of having a blood group of A, B, O, or AB, this individual has a blood group expressing both B and O. So detecting a separate cell population can be easy or difficult depending on what percentage of the cell is in the minor population and what percentage is in the major population, and what is present. So the reactions in these situations of chimeras are typically mixed field. Not because you see a mixed field reaction means that this person is a chimera. I want you to bear that in mind. But when we talk about chimeras, we have true chimeras, which only occurs in twins and is rarely found. So what happens is that two cell population will exist throughout the life of the individual. In utero, exchange of blood occurs because of vascular anastomosis. As a result, two cell populations emerges, both of which are recognized as self. So the body is recognizing both groups as itself, which means that the body will not mount a reaction against itself in a normal functioning individual. So this is a concept in immunology. If the body decides to mount a reaction against itself, then we would have a situation which would be considered an anomaly. And this situation, you can think about it and then indicate to us below so we know that you know the answer. And as a result, we have two populations taking place in the chimera. All right. And the individual, remember, will have these two populations existing in their bodies from birth until non-existence. And the individual will not make the anti-A or the anti-B. So in this situation, we are expecting isoagglutinins to be present, but guess what? They are not present in the reverse grouping. And it depends on the percentage of the population of red blood cell that exists in each of the twins. If the patient or the donor has a history of a twin, then the chimeras may be due to the patient has a history of twins, then it may be a chimera. If the patient has no history, then and they express a chimerism, what we could conclude is that this may be due to dispermy, which is basically two sperm fertilizing one egg. So we have two sperm, two sperm, fertilize one egg. All right. And individuals that is created is of a chimera expression, if we can call it that. And this would indicate mosaicism. If we it's called mosaicisms, something to that effect. So let me just spell it for you. It's MOSAICISM. All right. So that can exist. More commonly, artificial chimeras occur, which use a mixed cell population as a result. And these can be found in situations where there is blood transfusion. So let us say, for instance, group O cells are given to A or a B patient. So a chimera temporarily can emerge. based on the reaction. Then in situation where we have transplanted bone marrow or hematopoietic progenitor cell stem cells, that's HPCs, of a different ABO, we can have the development of a chimera. When we have exchange transfusion or fetal maternal hemorrhage, this can also induce a situation where we have chimerism being expressed. So we just need to be mindful of these situations that exist, and as we traverse our career in laboratory medicine, medical technology, clinical laboratory science, being a medical technologist, whatever it is, if you are practicing on the bench, you will be at the front line of this situation, providing that you're in an area where it occurs. And remember, even if you're in an area where it occurs, this situation is so rare that it is seldomly identified, but it is a possibility. All right? So just be mindful of that. When it comes on to type 1 discrepancy, we can have a situation in which we have a patient with a blood group. Let's do our forward grouping, FORWORD, forward grouping, and reverse group, REVERSE group. All right. So the forward group, we're going to have the anti-A and just the anti-B. Those are the only ones we're going to be using right now. And we may have the A1 cells and the B cells in the reverse grouping. A patient, let's say patient X, gives us a reaction of no reaction in the forward, no reaction in the anti-A, no reaction in the anti-B. When it comes on to the A1 cells, there's no reaction, and when it comes on to the B cells, there's no reaction. This here is problematic, and usually type 1 discrepancy is considered if there is a challenge in the reverse blood grouping, which means the A cells and the B cells are overreacting or non-reactive. So in this case, if this is a type 1 discrepancy, we're assuming that there is something wrong in the reverse. The antigens on the cells are usually reacting 3 and 4 plus. All right, so this would generally give us a 3 or 4 plus. If it's not reacting, then there's a high probability that the forward is usually the correct group. So in this situation, we are going to assume that this may have been a baby. This could have been a baby. This could have been a geriatric patient, an elderly patient. So those things do occur. All right. Beautiful. So now let us look at our chimera. So let us say that we have a patient. We're going to call them twin 1 and twin 2. And we're going to do the forward, FORWARD. Then we're going to do the reverse, REVERSE. So we're going to use the anti-A, anti-B. Let's put the anti-AB as well, anti-AB. And for the reverse, we're going to do the A1 cells, and we're going to do the B cells. All right. And then we're going to determine the blood group based on what we see. So, patient comes in, nothing in A, nothing in A for both twins. All right, that's fine. Then for the anti-B, we have a 2+ mixed field reaction. All right, mixed field reaction. For the AB, we have a 2+ mixed field reaction. Okay, all right. For the A cells, we have a 4+ reaction. Okay, and for the reverse, we have 0. That's for twin 1. For twin 2, nothing taking place in the anti-A. In the anti-B, we have a weak reaction. In the AB, we have a similar weak reaction. And for the A cell line, the anti-A1 cell reactivity, we have a 4+ reaction and no reaction in the B. All right. So in this situation, the 0 denotes negative, the MF denotes mixed field, and the WK denotes a weak reaction. So what we are observing here seems simple, but this is the red blood cell percentage, RBC percentage, that is being expressed. So for twin 1, we have 70% of B and we have 30% of O. All right. For twin 2, we have 30% of B and 70% of O. Now, isn't that amazing? That there is just an example of chimera situation that may be observed. All right. So now, let us bring our attention a little bit to the group 2 discrepancy. And the group 2 discrepancies are usually the discrepancies where we have challenges in the reactivities in the forward blood grouping. All right. So we have weakly reacting or missing reaction in the red blood cell grouping, which may be due to an excess amount of blood group specific soluble, or the BGSS substances present in the plasma, which sometimes occur with certain disease. So the disease state that an individual has predisposes them to produce certain or evoke certain reaction, such as when they have carcinomas of the stomach and the pancreas. We have seen excess amount of BGSS substances to neutralize the reagent anti-A and the anti-B, leaving no unbound antibodies to react with the patient's actual cells. And this will then yield a false negative or a weak reaction in the forward blood grouping. So the normal procedure to get rid of this is to wash the patient's cells of the BGSS substances with saline, and this should alleviate the problem, which will allow the forward grouping to correspond and correlate with the reverse grouping as expected. There are situations where antibody to low prevalence antigens in the reagent anti-A or anti-B can also cause a weakly reactive or missing reaction on the red blood cell when the blood grouping is done. But I must let you know that it is not feasible for the manufacturer to have all the blood group antigens to a particular anti-seria, because that would be taxing, time consuming, and cost prohibitive. All right, so we have to just bear that in mind. So when we have these discrepancies, we just try to use what we know to determine what we don't know, and then from that we deduce what is in the best interest of moving forward with the patient's blood group. So even though the situation is rare, it has been reported that the additional antibodies in reagent antiseries have reacted with corresponding low prevalence antigen present on the patient's red blood cell. Yes, everybody has a different mix of antigens on their red blood cell based on your genetics, based on your culturalization, based on your exposure. All these things can create different expressions of antigen binding sites. But there are some that are high prevalence, some that are low prevalence. Those that are low prevalence are the ones that sometimes are implicated in this kind of discrepancy. The procedure is, as we stated before, to get rid of it is to do washing, right? In situations like this, this produces an unexpected reaction of the patient's cell with the anti-A and the anti-B, or sometimes both, depend on the blood group, and it mimics the presence of weak antigen. So just bear that in mind. And the best way to resolve the discrepancy is by washing and repeating the forward typing using anti-sera from a different lot number. That usually just helps you to alleviate all the problems, all the challenges that you have, all right? So don't overcomplicate things. Just be strategic in how you assess and deduce what is taking place. All right, so let us try to do a blood group assessment. So let us say we have patient X, or let us call him patient 2, being that is a group 2 discrepancy. And then we have forward, FORWARD, and then we have reverse, REVRC. So we're going to use the anti-A and the anti-B. And then we're going to have the A1 cells, and we're going to have the B cells. So this patient has no reaction in the anti-A. It has a 1+ reaction in the anti-B. For the A1, there's a 4+. For the B, there is a 4+ as well. The first thing that I want you to always remember is that if you get a 3 or 4+, that is usually the indicator as to the correct blood grouping system, all right? So when we see a 3 or 4+, we're knowing that this is highly likely that this is a true reaction. So especially in situations where we have a 1+ reaction or a 2+ reaction, that there is suspect or questionable. What we're going to try to do now is to figure out why is it that this group is saying O, but this group right here is telling us that this patient is B. There is a discrepancy, B and O, all right? But this is a 1+, so maybe this here is some reactivity that is taking place that should not be taking place. And if we wash these cells and then re-perform the blood grouping, then there's a high probability that we will have this resolve, and then patient 2 will have no reaction, and a 4+ reaction, and a 4+ reaction, which would give us group O. So something like that can give us an idea as to a discrepancy that occurs in the forward. All right. Sometimes we have type 3 discrepancies, and type 3 discrepancies are common. They're problematic. There are discrepancies that most persons don't like to have to deal with. All right. So as we stated before, that type 3 discrepancies are between the forward and reverse grouping and are caused by protein or plasma abnormalities and result in rouleau formation. So, or pseudoagglutination, attributing to give us a reaction that looks like an agglutination, but we have to take that under the microscope to evaluate to see what is what. So a rouleau formation gives us a situation of the blood cells stacking on each other, giving us a reaction that shouldn't be there. So we have to do a microscopic examination, or in situations like these with the type 3 discrepancies, what we can do is a warm wash to get off the excess protein that is causing the cells to stick together. All right. So let us do a quick example. Patient patient. We're going to call this patient 3 because this is a type 3 discrepancy, or forward as usual, forward grouping, and we're going to do a reverse grouping. All right, so we're going to use the anti-A, anti-B, the A1 cells, and the B cells. All right. So this patient has a 4+ reaction in the anti-A, 4+ reaction in the anti-B, then they have a 2+ reaction in the A cells, 2+ reaction in the B cells. This is problematic because this here is saying that the patient is AB, and this here is saying that the patient is O. But when we evaluate the strength of the reaction, this reaction is lower. So the reverse reaction has a lower strength. So we are going to try to resolve it from where the weakest point is, and that is the weakest point. So what we're going to do is we're going to examine for microscopically to see if this is a true agglutination. We're going to do saline replacement technique, and we're going to wash the cells with saline for three times at least, and then we're going to run antibody screen as needed to resolve this type of discrepancy. After we have done that, we realize that we got a reaction 4+, nothing, and nothing, which would give us the group of the patient to be AB. All right. Now, there is another kind of discrepancy which is considered to be the type 4 discrepancy. And we're just going to touch on the type 4 discrepancy a little bit. These discrepancies are between the forward and the reverse grouping. They are due to miscellaneous problem, usually maybe cold reacting autoantibody, in which red blood cells are so heavily coated with antibodies that they spontaneously agglutinate independently of the specific reagent being added to it to cause antigen-antibody complex to form, right? So there is auto-antibodies causing an agglutination. And when this happens, circulating red blood cells tend to give a lot of problems when we're doing the grouping, especially when we do it at room temperature. All right. So this is where the DTT comes in very critical for us to resolve this kind of discrepancy. All right. So don't be afraid of this type of discrepancy. This type of discrepancy does exist and it is solvable. All right. And if we observe a cold reacting, the first thing that I want you to think about, after we have observed the reaction, we're going to try to wash the patient's cell with warm saline. And then we retest it, right? We're going to run DAT and we're going to run the auto control. We're going to run the auto control to see if there is auto antibodies. Then we're going to run the antibody screen as well. The DAT would indicate to us if there is sensitization to an external factor that went into the body, and the antibody screen would give us some indication of if the patient has any antibodies. All right. So that can be a possible solution. So let us try a patient 4, patient 4. And this patient, let's run that out, patient 4. And we're going to do the forward as always, forward. And reverse. So we're going to have anti-A, anti-B, A1 cells, and B cells, all right? So what if we had a patient with 2+ reaction in the A, we had a 4+ reaction in the B, then we had a 4+ reaction in the A, and a 2+ reaction in the B. This here is confusing because this here, the forward is saying that A and B antibodies are present, which means that this person would be AB. And when we come to the reverse, A and B cells reacting, which means that this person is O. But the person can't be AB and O at the same time, because you can't have the same antibodies to the antigen, because in that situation there is going to be a termination of the individual because agglutination would be taking place. All right. So next thing that we're going to look at, where is the weakest link, or where is the weaker link? So this is a weak link because right here we realize that that's a 2+ reaction. Usually a 2+ reaction is indicating a problem if it's not corresponding. So these two areas, the A and the B, have a 2+. So if we take out the A and the B alone, does this give us the proper group? So anti-B and A1 cells. Yes, that would be a B group right here if this discrepancy is resolved. So what we're going to do is wash the cell with warm saline, and we're going to do a retest. We're going to run the DAT, we're going to run the auto control, we're going to run the antibody screen, and then we're going to determine what the correct blood group is. After we have done that, guess what we came up with? We came up with no reaction, 4+ reaction. We came up with a 4+ reaction remain and no reaction. So this patient was actually group B. All right. So it's not that complicated. as long as you know what it is that you're looking for. So let us try another one. This one should be pretty easy, pretty straightforward for you to be able to identify. So patient group 4. And we're going to do the forward grouping. And we're going to do the reverse grouping. So the forward, we have the anti-A, anti-B, then we have the A1 cells, and we also have the B cells. Now, we have a reaction in which we have 4 plus in the A, 4 plus in the B, we have 1 plus in the AB, and we have nothing in the B. This looks like the patient right here is AB, and right here it looks like the patient is B. But we can't have AB and B in the same patient being expressed. And when we look at the weaker link, we realize that the A1 cells, where we have the reactivity, is a 1 plus. So what we could do is to say to ourselves, maybe this is a B person, but why is it that we're having some reaction with the A1? Is this normal? Yes, this is possible. We have seen this time and time again in our manual and automated methodologies, but this can be resolved. So what we need to do is assess the reaction with the A1 cells. Let us think of ourselves, or think to ourselves. You have A1, you have A2, you have A3, you have different subgroups of A. If we know that about 99% of the people are A1 and A2, and we have A1 being most prevalent, but there's a possibility that there is A2 that exists, then we're going to try to check with the A1 lectin to see if there is any reactivity with this patient cell. So we're going to test the cells with the A1 lectin. Then we're going to test the serum with the A1 and the A2. And also we're going to use the O cells, right? Then we're going to run the auto control. And then that should give us an idea that there is a possibility that this patient was actually A, B, but guess what? A2B, not A1B. So yes, it is that simple, but yet complicated simultaneously. So that is the nuances that exist. That's one of the nuances that exist in immunohematology. You know, you have patients with different situation, different discrepancies. You have to try to figure out what is causing the particular reaction, so that there can give some persons a thrill if they are of an investigative mind. But before we depart, I just want to bring your attention to a situation where antibodies other than the anti-A and the anti-B may react to form the antigen antibody complex that may then be absorbed on to a patient's red blood cell. When we're thinking about type 4 discrepancy. So one example that I want you to just bear in mind is that of an individual with an antibody against the acryloflavin, that is the yellow dye that is used in the anti-B reagent. So Just bear in mind, in the anti-B, we use a yellow dye. In the anti-A, we use a blue dye. And that there is just for you to have a mental picture of the reagent. So the acrylflavin complex can attach to the patient's red blood cell, causing agglutination in the forward typing. So washing the patient's cell 3 times with saline and then retyping should resolve such a discrepancy. But in some cases, you have a cis AB, which refers to the inheritance of both the A, B gene from one parent or one parent who is a carrier on one chromosome. And then guess what? You inherit the O gene from the other parent. All right. So this results into an offspring inheriting 3 ABO genes instead of 2. So they are inheriting the A, B gene from one parent, and then they're inheriting the O gene from another parent. So instead of having 2, they have 3. So this here is the cis AB. So this designation of cis AB is used to distinguish this mode of inheritance from the normal AB phenotype that we are accustomed to, in which the alleles are located on different chromosomes. The cis AB phenotype was first discovered in 1964 when a Polish family was described in which the father was group O and the mother was group AB and gave birth to children who were all AB. It was resolved by the fact that the A and the B genes were inherited together and were both on the same or the cis chromosome, thus the term cis AB. So yes, there are these situations that do occur, and the cis AB phenotype is a rare occurrence. An express weakly reactive A antigen and a weak B antigen simultaneously. The B antigen usually yields a weak reaction with the anti-B from random donors with mixed field agglutination, typically of subgroup B3, which has been reported in several cases. So the weak anti-B present in the serum of most cis-AB individuals lead to an ABO discrepancy in the reverse blood grouping. The serum of most cis-AB individuals contain a weak anti-B which reacts with every single ordinary B red blood cell. Yet, guess what? It does not react with the cis-AB red blood cell. And with that said, it is fair to say class is dismissed. Have yourself a beautiful day.